We'll talk about Basilica. We'll ask you the same question about Basilica after. I was asked to talk about Basilica and Unicorn step by step. And there's been a lot of discussion about that early on. So I don't think I need to go through this. We've had an extensive discussion, and maybe I'll try and go through this a little bit quicker so we have some time and maybe we can catch up. But we understand why we need to do Basilica and Unicorn. Miho did a great analysis in these morning cases. But it's just important to remember there are options. And in a sick 95-year-old, you may think differently than in a 78-year-old, right? So snorkel stand, chimney stand, all of those things are options. And so those are things to consider. There are risks with those strategies. The stents can get crushed, they can get restenosis. Re-engaging those coronaries is often incredibly challenging when the stent's sitting out like that. So those are all considerations and reasons why I would go against it. But there are scenarios, and we saw the case this morning where I don't know that Basilica has any role because the commissures are completely misaligned. That's not going to be true, hopefully, with a surgical valve, but with a TAV and TAV, you're seeing these patients and where the commissures are misaligned. So you might have to look at alternative strategies. So we'll skip through that. So I'm just going to go through how we do a case. There are different ways to do it, and I'm sure everyone's going to do it differently. But this is our approach. We get 14 French. We use the Gore dry seal, mainly just from it has better hemostasis valve, and we have left femoral access. And then we cross the aortic valve through the 14 French dry seal, sort of an unusual manner. We put a V18 wire, and then we advance a 6 French multi-purpose guide, or sometimes a JR4 guide, which I think increasingly I've been going to the JR4 more than the multi-purpose. So I would probably update this slide because this is how we used to do it in the past. This is going to be your snare catheter, and the JR4 gives you more control. So then we get another catheter across, and we cross the aortic valve again, and then we position a pigtail. The goal of this pigtail is that after you do the laceration, that way you don't have to work to cross the valve again, because sometimes patients can decompensate, so you can quickly put your safari wire through the pigtail and then deploy the valve. If you're doing Basilica in a patient with aortic regurgitation and you don't think it's going to be a hard time to cross, you can avoid putting this pigtail up front. And then we put the gooseneck snare in the multipurpose along the V18. The purpose of the V18 is to stabilize the guide catheter with the gooseneck snare. And so sometimes when you're trying to pull the snare, the guide comes out. That way, if you have the V18, you always have access to the LV. You can go back and forth. So here's what. Oh, there it goes. Okay, here now we are sort of aligning. We use, there are different catheters. In the U, we don't have any dedicated catheters, and typically we use an AL2 and a 5 French, either multi-purpose inside or a 5 French JR4. The key thing is when you're trying to get to a line for the Basilica, you use the fluoroscopic views to find the angle that opens up the left cusp at the base. We use TE a lot. We do all of our cases under TE because I think the TE shows you nicely that you're in the center of the cusp in front of the left main, as you see here. This is our catheter here. This is the left main, and you see in the MPR view, you see the catheter coming down. The main issue with the guide catheters, and what you want is you need the guide catheter to face in. You want the guide catheter to point down, and then the 5 French catheter inside, the multi-purpose and the JR4. You want as close to the base, but you don't want the catheter. You don't want the catheter pointing out. You want the catheter pointing in towards the LVOT. If you point out, and there have been cases where people have gone into the right atrium and other structures as you burn. So the trajectory of your catheter is important because that's the trajectory of your burn and where the wire is going to go. So and that's why that 5 French catheter inside the guide is good, because most often it's an AL2 that will point you down, but then that 5 French JR4 will help you point towards the LVOT. And you can, by how far out you extend it and everything else, you can do that. So then, using echo and fluoro, we verify that we're in front of the left main. And then we have an Estado 30 wire in a micro catheter. Typically we use a fine cross now. This was an older case, and back then we used to use the piggyback catheter. And so here, again, we're right in front, and you see the burn. And the burn should be short. Again, you do it on cut, not on coag, because you want to minimize that. And you want to minimize the burn time. So one person's doing the burn and the other person is advancing the wire. And it should be just 2 seconds, right? As soon as you burn, you advance the wire and then you come off. If the wire's not going, then stop burning, and there's a reason it's not going. Either it's too calcified there, in a surgical valve, you're pointing towards the sewing ring and not towards the leaflet. That's the most common thing. This is a Basilica that we did in a native, but if you're doing it in a surgical valve, again, you're going to see the frame of the valve and you want it to point in. And so the most common reason the wire doesn't go is you're headed towards the sewing ring. So if it doesn't go, stop. Don't just keep burning. You're just going to cause injury and coagulation in the blood. So now, once we've crossed, we have to snare the wire in the LV. And so before we cross, we using JR4, we open up the snare and we try to have it fill up the LVOT. You want it just underneath the aortic valve ideally, but sometimes that's difficult, but you want it fully open underneath the aortic valve. And then you close the snare and you try to capture. Every time we snare, one thing we always look at is the MR. In this patient, it had minimal MR before, and after snaring, there was a lot more MR. This was a case where we had a hard time snaring, and we ended up going a little bit too low with the snare. And so we ended up probably the wire went on one side of our cord and we snared on the other side. And we knew it because as we tried to pull up, we couldn't come up to the leaflet, there was resistance. And you look on the echo and there's a lot of MR. So you then had to go, this is a different patient example, I'm just showing this, but we had to snare higher in the LVOT. This is a patient that had a prior mitral valve repair. And so you snare it higher, and now you see again, the MR is back to its baseline compared to earlier when it was a lot worse. So after snaring, especially if it was difficult and you're snaring low, just check the MR to make sure you haven't caught any cords. So next, you have to scrape the coating off the Estado wire because it's insulated. So where you scrape the coating is where the energy is going to be delivered. I forgot to mention before you burn the first time, you scraped on the back end of the wire so you could deliver with the cautery. So you sort of see here we make a small scrape and then you make a little bit of a V, and then you have your microcatheter as close as possible. The reason being, when you deliver energy, it's sort of disseminated, and ideally you want to concentrate that energy as much at the tip, just as the leaflet as possible. The more disseminated it is, the less effective your cut's going to be. Because what you don't want to do is tear the leaflet. You ideally, using the electrocautery, want to cut the leaflet. But if you're not delivering the energy efficiently, you're going to more tear than cut. So to try to get at the tip, we have a guide catheter that you have all the way down. You want to cover as much of this as possible when you're delivering your flush. So you want to try and create as much of a blood-free zone right at that tip as possible. So you can bring your guide catheter, your fine cross, everything right as close to that flying V. So as you inject the saline, you create that space and you concentrate the energy at the leaflet rather than disseminating it through that entire space. So here, we pulled the flying V, it projects well, but we basically, using the snare catheter, we pulled it from the other side. So now the end of the wire has come out one side, and you advance the flying V. So now you have control of both ends of the wire. And the flying V is at the level of the leaflet, and you're ready to cut. Before you cut, what you want to do is get rid of all the slack. Oftentimes this catheter, there's two catheters here, oftentimes this catheter is on the outer curve, and if it's on the outer curve, as you're pulling, you're not really pulling on the leaflet. So you want these two catheters as close as possible, and then as you apply the energy, and again we generally do it on 50 a cut, you pull, and it should be a nice easy pull, and ideally it goes through. The challenge is the cut, depending on the aorta, may not always be to the center of the leaflet. It can go towards a commissure. If there's calcium, it can go in a different direction, so it's not always perfect. So this generally requires 3 people as part of the team. One person's injecting, one person's pulling, and one person's hitting the cautery. And so you need to have extra hands. So I'll skip through this. We just did a TAVR, and we saw a normal flow in both the coronaries. But it's complex, and that's why it's not done routinely. It's not completely predictable. You know, calcium, the angle of pulling may change where you put the cut. So the question is there a simpler way? And I would highlight the fact that simpler is not always better, but this is an example of the unicorn procedure, where again, you do this, initial part is the same, and I think we saw this earlier, so I might skip through it. Ravinder talked about it, is, you know, you traverse the leaflet, you put a coronary balloon, and then after you've done the coronary balloon, you advance your guide in, and then you do a slightly bigger balloon. The idea with balloon expandable is to generally, you know, deploy the valve in the leaflet. The problem is when you do that smaller balloon, sometimes you may end up tearing the leaflet. As you put the safari, you may tear, so it's not always that way. But as we said earlier, for self-expanding, you need to tear the leaflet, because if you don't tear it, you won't expand in the leaflet. So this is a case example is from Azim here. I couldn't find one of ours, but you know, use the AL2. He crossed here, and then he advanced the microcatheter. In just time, I'll go a little bit quicker. 5mm balloon, and then did an 18mm true balloon to really just lacerate the leaflet. After he did that, you can see that here. We'll see the true balloon inflating here. You see the waist in the leaflet, and I'll let that play again. In a second. You'll see the waist in the leaflet, and then you'll see it go away. And that's the balloon sort of tearing. And again, you go across the other side. You can see that on echo as well, the balloon fully inflated. So now, the patient's going to have torrential AR, and you're going to, and this is self-expanding, and that's why you fully tear the leaflet, and you put the self-expanding valve in, and you see here on echo as well, you know, matching the inflows, and you see good coronary flow here. So I know it probably doesn't need to be said, but I just want to emphasize, you know, the first case I showed was a Basilica and a native. This isn't a TAV and TAV. You can't do a unicorn and a native, right? Because if you inflate the balloon in a native leaflet, there's calcium, it can tear the annulus. The balloon path may tear the annulus. So just remember, unicorn is only for, you know, stented surgical valves or TAVR devices, because you have to be cautious. So I'll stop there. You know, I think it's a physiologic approach to prevent coronary obstruction. So you don't have to stent, and it'll provide easier access to the coronary arteries compared to snorkel stenting. We've seen earlier today, complexity requires careful case planning, and you have to do a risk-benefit discussion with each patient depending on, you know, patient's age, the risk of the procedure versus the risk of surgery, and all of the factors. So thank you very much.